The GU case is a 42-year-old woman. She was G6P5 and she was previously healthy. And she presented to community primary care with irregular periods and abnormal vaginal bleeding. This prompted an ultrasound, and here you see two images from a transabdominal ultrasound, both grayscale and color Doppler. And you can see that there is a mass located in the central uterus. It is a mixture of solid and cystic components. By location, it's concerning for an endometrial-based mass. You can see in the solid components that there is vascular flow. There was also transabdominal imaging performed, which I think actually shows the mass worse than the transabdominal imaging. But one reason I included this image was because it shows these little tiny cystic spaces. Okay, so based on these, the clinical presentation of bleeding and the ultrasound appearance, the clinical suspicion was for endometrial cancer. So she went on to have tissue sampling through DNC, and this led to significant hemorrhage, and so much so that the patient ended up admitted to the hospital and in the ICU. At that time, they decided to draw some beta HCG levels, which were found to be elevated. A low initial reading of only about 1,100, but ultimately a second test was performed that showed a level of 1,000,000. This raised a concern of gestational trophoblastic disease. She was further evaluated with a CT and MRI. Here are three different post-contrast CT images, and you can really nicely see the extent of the abnormality. There is a mass expanding the endometrium, kind of thinning out the myometrium. It is mostly very low in attenuation, and if you look very closely, you can imagine that there may be some little tiny cystic structures in there. Now, the solid components are extremely vascular, which is common in the setting of gestational trophoblastic disease. Here are some MR images, and this is a coronal T2-weighted image, and I think it beautifully shows the little tiny cystic structures that make up the bulk of this lesion. It has a grape-like appearance. And then our post-contrast images again nicely show the hypervascularity of the hyperplastic trophoblastic tissue. Okay, so the original biopsy sample came back and it showed that there was indeed a molar pregnancy, and there was an area concerning for trophoblastic cells invading into the myometrium. At this time, the patient opted to have a total abdominal hysterectomy with ovarian sparing bilateral salpingectomy. Here is the gross specimen of the uterus, which I think beautifully correlates with the MR image, as you'll see here. There are numerous tiny cystic spaces all throughout that expanded endometrial canal, really nicely correlates with the little T2 bright cystic spaces. In addition, there was sectioning of the uterus done, which showed the molar pregnancy here with the multiple cystic spaces and its relationship to both the endometrium or decidua and the myometrium. It looked like it extended up to, but did not clearly invade the myometrium, at least at gross pathology. On closer inspection at histology, you can see again the molar pregnancy here and its relationship to the myometrium, and that there was mild kind of superficial invasion of the myometrium. Here are higher power histology images where we can see that the villi are dilated, resulting in these cystic spaces. These are the areas that are low in density on CT and bright on T2 signal intensity, and they're surrounded with hyperplastic trophoblastic tissue. We can see that a little bit better here at the slightly higher power, where again, we have these dilated edematous villi aligned by the trophoblastic tissue. Okay, that trophoblastic tissue is very vascular, as we saw. Okay, and then here are areas of invasive behavior. Although the invasion was relatively superficial, it involved both the myometrial layer as well as into the vascular spaces. Okay, so here's our summary slide showing this beautiful example of an invasive complete molar pregnancy with the little tiny cystic spaces and hypervascular trophoblastic tissue. So thank you very much for the case submission. It was submitted by Dr. Michael Wayne. So congratulations, beautiful case.